Hello, my name is Chris Scott. I'm a pediatric rheumatologist from Cape Town in South Africa. I am the chairperson of the International Clinical Council for FOP, and I'm the director of the Clinical Research Center at the University of Cape Town. My job today is to talk to you about flare-ups in FOP. Flare-ups are a major part of FOP, and as a clinician, if you're managing FOP, flare-ups are the things that kind of keep you busy. They're also the bits about FOP that really are concerning for patients and that make patients really anxious and worried. So having an approach to treating flare-ups is essential. But the question really is what is a flare-up? As you know, FOP is characterized by this relentless bone formation, and that bone can sometimes, or often, or a percentage, or some of that bone progresses without any flare-ups happening. But flare-ups often are the first sign of FOP, and also often are a sign that new bone formation is happening. Flare-ups represent the inflammatory side of FOP, and if one digs into the way that FOP works, inflammation is a core player in this process of new bone formation, and muscle injury and muscle fatigue and muscle death are things that trigger inflammation, and that inflammation can become exaggerated, and that exaggerated inflammation surrounding in muscle, which sometimes leads to new bone formation, is what we call a flare-up. So it's basically an immune response that's present in the early phases of a flare-up. The inflammation of a flare-up can start from a trigger. It can start from an injury, something we're dead keen to avoid. In people with FOP, as you will probably have heard, we do not allow for any interventions by medical professionals or others that may actually trigger harm to muscle and therefore lead to a flare-up. For instance, intramuscular immunizations are to be avoided. Surgery is to be avoided at all costs if it's going to involve any muscle. Overexertion of muscles, such as extreme exercise or stretching or physiotherapy, is to be avoided, because all of that can cause muscle injury. That muscle injury can set up an inflammatory response, and that inflammation can then be the beginning of a severe flare-up. On the other hand, other more general stresses that are not specifically related to muscles, such as severe viral infections. We all know people can get muscle aches from viral infections. Probably viral involvement within the muscle cells can damage them as well. These can cause flare-ups, and some flare-ups can just start spontaneously. But usually injury is what causes flare-up. And flare-ups are therefore characterized by the signs of inflammation. So we all learned in medical school that the signs of inflammation are warmth, redness, pain, swelling, and loss of function, the so-called pillars of inflammation. And these are indeed then the signs that are present when we have an FOP flare-up. Some of not, but not all of these signs can be present all at the same time. But usually a combinations of these are a sign that something is a flare-up and not just slow new bone growth. But we do know from a paper done by Bob Pignolo and others on the natural history of FOP that 93% of people reporting a flare-up report swelling as part of that flare-up, and 86.3% report pain. Slightly less than that, 70 or so percent report decreased movement, and stiffness, warmth, and redness are seen as well, but in lower frequencies. People are actually quite good at recognizing flare-ups, and in that same paper by Dr. Pignolo, it's been shown that most people, nearly 50% in fact, are able to identify a flare-up within the first 24 hours of the flare-up occurring. And 17% of people can identify them absolutely immediately the minute they start. This has implications for how we treat FOP flare-ups, and recognizing one is, of course, the beginning of being able to treat a flare-up effectively. How long do flare-ups last? Well, it depends on where they occur in the body. Flare-ups in the back and in the hips tend to last quite long. More than 70% of people report that flare-ups in the back last more than 12 weeks, and more than 60% of people report that flare-ups in the hips last more than 12 weeks. We can see that people with flare-ups in the head and jaw, for instance, report lower percentages, and in the head, only 25% of people report flare-ups lasting more than 12 weeks. So it really depends where your flare-up is, and back and hip flare-ups tend to last the longest. As to where flare-ups happen, flare-ups tend to happen in the same course as the ossification happens. So as we know in FOP, the new skeleton, the new bone that is laid down in a way that mirrors the laying down of the embryonal skeleton, meaning that the earliest part of the flare-up involvement usually is in the head and neck. In the mid-teen years, from 9 to 14, it moves down to the lower back and shoulders, and when children are older than 15, it moves down to the hips and legs. And so it really depends on your age where your flare-up happens, and it starts top to bottom and out, in and out. FOP, however, doesn't need a flare-up to progress. Flare-ups happen, and some flare-ups result in new bone formation, but many people have flare-ups, have no flare-ups, but still have bone progression. So that happens in up to 90%, 40% of people will have bone formation in the neck without showing a flare-up, for instance. About 1 in 5 flare-ups will resolve by themselves completely without any treatment whatsoever. So what do we do when people have flare-ups? Well, since inflammation plays a major role in the symptomatology of flare-ups, our first job is to try and settle the inflammation down. And as clinicians and physicians, we all know that our go-to medication when it comes to inflammation is methylprednisolone or one of the prednisolone or one of the corticosteroids. And in fact, in FOP, because there's often a delay in finding healthcare workers that are knowledgeable about FOP, and the fact that patients are often able to identify their flare-ups themselves as early, as I said earlier, by 24 hours, we often advocate that patients carry with them some prednisone, the pill-in-the-pocket approach, where they carry the prednisone with them, and at the first sign of a flare-up that they're pretty sure is a flare-up, they can start using prednisone to reduce the intensity of the pain and hopefully to abrogate some of the inflammation and perhaps have an effect on the bone formation, although there is no evidence that prednisone stops new bone forming once a flare-up has happened, and we know bone forms even if there hasn't been a flare-up. Having said that, it's lovely to be able to do something, and so we give steroids to settle down the inflammation and to settle down the pain of the flare-up, and try as much as we can to remove that component from the new bone formation as well. So the pill-in-pocket approach, we give all our patients a prescription for at least 5 days of prednisone should a flare-up happen. We also tell them that if they anticipate a flare-up, so for instance, if they've had an injury that they suspect might cause a flare-up, for instance, someone's got a bump on their thigh and they've developed a huge bruise, we can confidently say that there's a risk of a flare-up in that area. We might advise people to then start prednisone even before the flare-up symptoms have started. There are some other things that we can do for a flare-up. The first is to avoid muscle injury, so avoiding strenuous exercise, not to play contact sports like football or in my part of the world, rugby, and so as not to injure muscle or to overexert muscle. One can use cool packs to take away the symptoms of the flare-up, to cool down the area as you do for any other inflamed area, a sprain or something like that. And one can also use non-steroidal anti-inflammatory drugs such as ibuprofen or diclofenac or one of the COX-2 inhibitors to try and limit the amount of inflammation. These can often provide quite a lot of symptomatic relief, but again, they don't actually influence the rates of new bone formation. Some other agents can be tried during a flare-up, and in the modern age, we are in the position where a new drug has been approved for therapy for FOP. Its role in preventing flare-ups is yet to be clarified, but it may be that there's a role for the newer agents that are being developed in terms of managing acute flare-ups. And indeed, during some of the clinical trials, there are flare-up based dosings that used where the dose of the drug goes up in the event of a flare-up to try as far as possible to stop new bone formation. People have used bisphosphonates and other drugs as well, but these usually should be managed and given by someone who's expert in FOP, or at least be discussed with them before it's given. We also don't like to give opiates and such as morphine or oxycodone or such like drugs to manage the pain of flare-ups, because we know these flare-ups can last, as we said earlier, up to 12 weeks in specific areas, and there's the real likelihood that trying to just manage pain with opiates could lead to an overdependence and over-reliance on opiates. So the best way to prevent flare-up, the best way to treat flare-ups is to prevent them, and the best way to prevent them is to not have surgery to the muscle, not injure the muscle at all, not have intramuscular injections, and not to have over-vigorous exercise or physiotherapy. And if one of these things has happened and you think a flare-up is imminent, then it might be good to start therapy with prednisone even before that. Remember, prednisone has obviously very severe side effects, especially if taken for longer term. So if flare-ups are present in the back or neck, in the back or neck, as well as the hips, we tend to avoid using prednisone because the flare-ups can then the steroid courses tend then to be very long in order to control these very long flare-ups, and then the steroid exposure might not be in the patient's benefit. One flare-up that we're very worried about is flare-ups of the submandibular area. So if there's a flare-up there, we would tend to be quite aggressive with steroid therapy and try to relieve the inflammation in that area as quickly as possible. The reason for that is submandibular flares can cause swelling of tissues around the airway, and this can actually lead to threatening the airway. And so we're actually very, very cautious about treating those and tend to be quite aggressive with steroids when submandibular flare-ups are present. This may even require hospital admission so that children or adults with submandibular flare-ups can be monitored and so that they don't develop airway problems. So as I mentioned earlier, there are many other medicines that are used in treating flare-ups or sometimes preventing them. To date, only one drug has been approved for treatment of flare-up of FOP in general. That drug is palovarotene. It's been approved in Canada and the USA, but not been approved in the EU. But this is likely to be an evolving landscape where new agents are likely to be approved in the coming years. And the ins and outs of how to use these new therapies is also something that will develop with time. And so I can strongly recommend that if you're looking after a person with FOP, that you keep an eye on the International Clinical Council's website for the ICC Medical Management of Fibrodysplasia ossificans progressiva treatment guidelines. These guidelines are updated very frequently. The last one was in May 2023. And we tend to update these as soon as there's new information, and we'll certainly be updating them for all the new medications as and when they become available to manage flare-ups in FOP. I think that brings us to the end of this discussion. So to summarize, I'll just say that flare-ups are recognized easily by patients. They're represented by swelling and pain mostly. And at the moment, the current therapy for flare-ups is to use short courses of corticosteroids in doses of 1 to 2 milligrams per kilogram for 5 days in order to settle down any swelling. And some flare-ups, such as in the jaw, require special attention, whereas others, such as those in the spine, need to be managed differently so as to avoid an overdose of corticosteroids. I hope this has given you some insight out into how we manage flare-ups, and I hope that you consult the ICCFOP.org website in order to learn more about managing FOP. Thank you for your time.